Well, I'm very thankful to the organizers for inviting me back this year. I always enjoy doing this very much, though this is the first time I've done it from my home, so hopefully this will work out okay. Just some disclosures. I have research grants from Beyond Air and Matinas Biopharma, and then unpaid consultancy to Spiro, Insmed, AN2, Quorum, and Auricula Therapeutics. Just a couple of comments about FDA drug approval. Emmicasin liposome inhalation suspension, or ALIS, is approved for treatment of refractory CAVIUM Complex lung disease in non-CF patients. It's the only drug that is FDA approved for treatment of pulmonary NTM disease. The other drugs that I'll discuss are mostly approved for treatment of tuberculosis or other infections. So the NTM are ubiquitous environmental organisms. There's over 190 species. I put a website there if you want to keep track of how many they are. Most of these are not new discoveries. The molecular microbiology lab has been very good at dividing what was formerly lumped together, and sometimes it makes differences in terms of treatment, and I'll go into that a little bit on a subsequent slide. But the three species that I think are most important for human disease in the US are CAVIUM Complex, which is made up of 12 species, M. abscessus group, which has 3 subspecies, which end up being very important for treatment, and M. kansasii, which ends up being the easiest to treat of these 3 groups of organisms. 80% of the disease involves the lung, less commonly skin and soft tissues, and fairly rarely disseminated disease. Classically, the NTM lung disease has looked like this cross-section axial cut of a CT scan with upper lobe fibrocavitary disease. It occurred predominantly in male smokers. It was characterized by very heavy burden of organisms, very difficult to treat, and the pathogenesis of this was not a great mystery. These are patients in whom mucosal barriers were destroyed, typically because of heterogeneous upper lobe predominant emphysema. This disrupted barriers allowed these relatively lower virulent organisms to take hold and cause inflammatory changes that then progress the lung disease. They're characterized by poor clearance in the airway areas of these cavities and allow for opportunistic infections. We now are aware of much broader susceptibility to these organisms, and epidemiologically they appear to be increasing year by year since about the mid-1970s. There's still patients seen with impaired local defenses, and they have underlying conditions such as COPD, bronchiectasis, pneumoconiosis, or prior cavitary tuberculosis. Most of these conditions are easy to pick up on clinical history, chest imaging, or pulmonary function tests. There are 2 monogenetic diseases you ought to keep in mind in association with these organisms in pediatrics. And outside of these 2 diseases, with the exception of concomitant immune suppression or underlying malignancies, it's relatively unusual to see these infections in children. However, they're very prominent in both cystic fibrosis and primary ciliary dyskinesia. I'm sure you're all aware of the diagnosis of CF, and I see that McGee Lee gave a presentation earlier in the seminar on PCD, and I'm sure she went through the diagnostic criteria for that disease. With regard to impaired systemic immunity, more frequently, especially with primary immunodeficiencies, what's seen as disseminated disease, but there are some examples of pulmonary predominant disease, and most notably the hyper-IgE or autosomal dominant STAT3 deficiency, which is diagnosed typically by very high total IgE levels, cardinal clinical features, and especially STAT3 genotyping. About 75% of those patients develop bronchiectasis, and 1/3 of them will be infected over their lifetime with NTM. Immunosuppressant use, such as TNF-alpha blockers, can predispose to either disseminated disease or pulmonary disease, and drug history will usually easily give you that factor. If you exclude all of those conditions, we're left with a fairly large and increasing group of patients with idiopathic disease. This has been coined the Lady Windermere syndrome, and typically this is diagnosed by clinical history. These typically are postmenopausal women who present with chronic cough, and excluding other conditions, many of them have special or unique body morphotypic features which overlap with conditions like Marfan syndrome. In terms of guidelines, this is hot off the press. These are 5 years plus in the making. The revised treatment of non-tuberculous mycobacterial pulmonary disease guidelines was a collaboration of 4 societies: the ATS, European Respiratory Society, European Society of Clinical Microbiology and Infectious Disease, and Infectious Disease Society of America. And the guidelines are focused on 22 PICO-type questions, which cover the more common organisms of CAVIUM Complex, M. kansasii, M. xenopi, and Mycobacterium abscessus. They're focused primarily on treatment in adults without cystic fibrosis or HIV. In addition to this, though a bit older, in 2016, the US CF Foundation and the European CF Society published recommendations for management of NTM in individuals with cystic fibrosis. And the marching orders for these guidelines were very different than the multi-society guidelines that just came out. In these guidelines, we were asked to present practical real-world recommendations for diagnosis and management to allow the practicing CF clinician to be able to see these patients and to be able to at least get them started on treatment. And for the most part, those that respond should do well following these guidelines. So I'll try to cover both of these and switch between the two of them as we go through the talk. These disease criteria were created back in the 1990s, and the goal then was to increase the specificity of finding NTM from a respiratory tract specimen. And the concern, though it's still not clear how big a concern this is that since these organisms are common in our potable water supply, you could take a big swig of Bethesda tap water, cough up sputum, and occasionally have a positive culture that represented oropharyngeal contamination or ingestion of these organisms and regurgitation back into the lungs unassociated with disease. And so to meet these criteria, you have to meet all 3 of the clinical conditions. You have to have either pulmonary or systemic symptoms. And those are things like frequent throat clearing, cough, they may have fever, night sweats associated with it. Radiographically, either nodular or cavitary opacities on chest X-ray, or bronchiectasis with small multiple nodules, what the radiologist typically call tree and bud infiltrates by CT scan, and I'll show some examples of this. And then you have to be able to exclude other diagnoses like bronchogenic carcinoma or endemic fungal infections. In addition to the clinical criteria, you need to meet at any one of the following microbiologic criteria. Ideally, patients would cough up early morning sputum specimens at least on 3 different days and have 2 of those positive for the same species. In patients who can't cough up sputum, a single bronchial wash or lavage is sufficient, or if the patient has had biopsies that have shown typical histopathologic changes of caseating, non-caseating granulomatous inflammation, a positive culture from any respiratory source will make the diagnosis. The first case I'd like to review with you is an illustration of this nodular bronchiectasis we talked about. If you look at the CT scan represented here, there are areas of nodular infiltration that sort of accompany the bronchovascular bundle. There's evidence of bronchiectasis on the slide here. And this was from a 77-year-old woman who presented with typical symptoms of productive cough that had been going on for about 2 years. There was concern for bronchogenic carcinoma in this patient, even though she was a non-smoker, and the patient underwent a surgical lung biopsy, which was put entirely in formalin, which then showed caseating granulomatous inflammation. She was then able to cough up sputum specimens that were both smear and culture positive for MAC. And so this brings us to our first audience response question, and that is, should patients with NTM pulmonary disease be treated with antimicrobial therapy or followed for evidence of progression, what's called watchful waiting? This isn't a trick question. I'll explain as we get to the answer part, but your choices are A, antimicrobial therapy, or B, watchful waiting. If you go ahead and fill your answers out there, I'll give you a few seconds. Okay. So antimicrobial therapy wins 63% to 37%. I'll stop sharing the results here, and we'll move to the next slide. So according to the guidelines, in patients who meet diagnostic criteria for NTM pulmonary disease, the suggestion is to initiate treatment rather than watchful waiting, especially in the context of positive AFB sputum smears, such as this patient had, and or cavitary lung disease. And this stems from now multiple sort of natural history studies where patients have been observed over a period of time, and then characteristics of those who progress versus those who don't have been delineated. And a large percentage of these patients will progress off treatment. So the concern is by delaying treatment that you may allow progression of the underlying disease. So this is a bit controversial, and there certainly are patients who may meet the criteria and then not progress, or at least not progress over a long period of time. So I think the bottom line is if you don't initiate antimicrobial therapy at the time that they meet diagnostic criteria, that these patients need to be followed relatively closely. So in terms of treatment of Mycobacterium avium complex in this type of patient, which is the nodular bronchiectasis disease and relatively mild, though it's quite apparent on CT scan, the recommendations are for thrice weekly dosing of a macrolide, either clarithromycin or azithromycin. The new guidelines have a preference for azithromycin primarily to reduce the number of pills being taken, but also it reduces drug-drug interaction. And then coupling that with ethambutol and rifampin. And this is one of the takeaway points from this lecture I'd like you to remember. The ethambutol and rifampin, a primary purpose of these drugs is to prevent resistance from developing to the macrolide. They're very, very important parts of the regimen. While for MAC pulmonary disease, in the past, it wasn't clear in the guidelines about whether they should be tested for susceptibility. The current guidelines recommend susceptibility-based treatment for macrolides and amikacin. And the reason is that these are the two drug classes that do correlate with clinical outcome. And the guideline committee felt that you should know up front or relatively soon after initiating treatment whether or not the patient is macrolide resistant, because it changes prognosis and likelihood of response to treatment quite significantly. So do these drugs work? And so the answer is yes, they do, but everything is not as it's published. And this is just an example from the literature. There are now a couple of other studies that have shown very similar findings. And in this study out of Texas, they started with 424 primary treatment episodes. And what's important are the boxes in red. And so right up front, they failed, patients who failed to complete greater than 6 months of treatment or were not evaluable constituted 17% of the patients. They were excluded before calculating the percent of culture conversion. They were then left with 353 evaluable patients, and of those, another 17% failed to convert. And conversion was defined as successive monthly sputum cultures times 3 that were negative, going from positive to negative cultures. So 83% culture converted. Those numbers sound fairly good. However, there were patients who relapsed on treatment, or treatment was stopped with less than 10 months of treatment. That constituted about 30%. So they were then left with 207 patients who completed greater than 10 months of effective treatment. So if you look at where they started, that's less than 50% who had a complete response to this. The next part of this is quite important as well. Of those patients who successfully completed treatment, and they had 10 months or greater of successive negative cultures, they were followed for 2 to 4 years, and of those patients, a little more than a third had microbiologic recurrences. Now, they had banked the initial isolates, and they compared them to the post-therapy recurrences by pulse field electrophoresis, and the vast majority of these were new infections. And so the bottom line here is whatever predisposes these patients to infection for their initial episode, that predisposition, we're not very good yet at figuring out what that is or how to fix it. That doesn't go away, and these patients remain at high risk for repeated infections over time. So getting back to our case of the patient who presented with 2 years of symptoms, diagnosed with MAC. She was started on thrice-weekly therapy with azithromycin, ethambutol, and rifabutin, and then referred to the NIH 1 year later, again with positive smears, heavy growth of MAC, a 40-pound weight loss in the prior year, fatigue, a decrease in exercise tolerance. And this brings us to our second audience response question. This patient is failing treatment. What is the most likely reason? A, only taking meds 3 times weekly instead of daily. B, she was prescribed the wrong medications. C, medication side effects led to poor adherence. Or D, she has macrolide-resistant Emmicasin complex and needs Emmicasin. And if you would, select your answers. Okay, so the most common answer we have is D, followed by C. I think either of those answers could have been correct. The correct answer was actually C, and this is just to emphasize the importance of the poor tolerability of these medications for treatment of NTM. Side effects are very, very common. It's unusual to hand the patients, 3 bottles of medicines and tell them to take them and see them back in 6 months without any problems. It does take some give and take to get patients to start on this. And so I have some tips for tolerance of this medication regimen. We generally stagger the drug start. I generally start with the macrolide to make sure the patient's able to tolerate that. In the 2nd week, we add ethambutol on, and in the 3rd week, we add on rifampin, which tends to be the least well tolerated of the 3 drugs. Sometimes dosing at bedtime can get around the non-specific GI upset that some of these drugs can have. Altering the dose schedule might be helpful, splitting the dose instead of taking them all at once, which is generally recommended. The use of probiotics, they may need to be used at higher than usually taken doses, but sometimes that can be helpful in treating antibiotic or managing antibiotic-associated diarrhea. And then drug substitution, and I'll go over some drugs that may be potentially helpful for Emmicasin complex if you need to alter the regimen. Drug toxicity monitoring is extremely important. This needs to be prospectively set up at institution of the treatment, and this needs to be tracked as the patients go along, because they almost certainly will develop some drug toxicity, and making sure the patient and the treating clinician are both aware of what to look for is very important. The macrolides are generally pretty well tolerated, but they can prolong the QT interval, and if you're stacking drugs like quinolones or clofazimine or azoles, you may run into problems with the QT going out. Azithromycin at higher doses can cause some hearing loss. It's just important to be aware of that. And then the concern for resistance with monotherapy, and monotherapy really should not be used to treat any of these NTM cases. Ethambutol, about 10 to 15% at recommended doses will develop optic neuritis. We generally have the patient see an ophthalmologist at baseline and then follow up at 6-month intervals. The patients can also do color vision screening, and there's a website listed there that we give our patients and ask them to do that at whatever interval they're comfortable with, and that can pick this up early. It tends to reverse if it's found early and stopped. Rifampin, it's important to tell them that their urine will turn orange, and the biggest issue with rifampin, aside from some GI upset, is its drug-drug interactions, and particularly with drugs like the CFTR modulators or post-transplant immunosuppression, this becomes a very difficult drug to use in the regimen. Emmicasin and streptomycin, which we'll talk on a subsequent slide, very common ototoxicity. It's really important to get baseline audiometry and to follow that at regular intervals, particularly if they're on IV forms of these drugs. Rarely there can be some nephrotoxicity, but that's usually seen when combining it with other nephrotoxic drugs. So let's move on and talk about what this looks like in terms of treatment if you have a CF patient. So this was a 14-year-old male with cystic fibrosis. He was diagnosed with MAC from sputum and BAL and was smear negative at age 14. Patient was diagnosed with CF at age 2 with a positive sweat and was F508del and an unknown mutation. His first IV antibiotics were at age 12 for methicillin-sensitive staph, and he had an FEV1 impairment in the mild range. And so in terms of diagnosis and treatment of NTM and CF, and these come from the CF guidelines, the recommendation is that the diagnostic criteria of the multi-society guidelines do apply to CF with the following caveat. Since other CF pathogens and comorbidities can be present and may complicate the significance of the NTM, the recommendation is that those should be considered for treatment initially when determining the clinical significance of positive NTM cultures. And so if the patient's growing out Pseudomonas and staph, recommendations would be to treat that aggressively first and then reassess whether the NTM is still present and whether it is contributing to the current radiographic changes. This regimen is the same for MAC, but the recommendation is for daily dosing rather than intermittent dosing. So a typical MAC treatment schedule might look like this. The time and duration is across the top of the chart here. And the circles underneath that represent intervals obtaining sputum culture. So the recommendation is to obtain these monthly. That may be difficult to do in your center. We actually have a send-in capability and are better able to do that, but even so, it's difficult. But the crucial period is the initial 4 to 6 months. And the reason for that is you want to mark the point at which the patient goes from positive, represented in the black circles, to negative, represented in the open circles. And that starts your time clock for treatment. So recommendations are to treat for 12 months after conversion from positive to negative. And so in this example, that would take your treatment out through 16 months. The stars there represent recommended time points for CT of the chest. The 6-month interval is important because if the patient's not responding microbiologically, clinically, and radiographically at that point, the recommendations would be to add or change the regimen. The bronchoscopy with a question mark at the end of treatment is somewhat controversial, and this represents patients that are not able to bring up sputum, and the question is then, should you rebronch them subsequently if they've otherwise got signs of clinical improvement to prove that microbiologically they've responded? I don't have a great answer for that. I think it depends on the patient and the clinical situation. The drugs are shown next, and then toxicity monitoring at the bottom. Their recommended frequency of blood tests is a little more frequent than what we do, but I mentioned the ophthalmology importance with regard to ethambutol follow-up. How about cavitary Emmicasin complex? This represents a stepping up of the disease severity. This also is a case of a 14-year-old male with cystic fibrosis. This patient was diagnosed at 9 months and had Pseudomonas at the time of diagnosis. Emmicasin was found at age 11 when he presented with fever, fatigue, and weight loss, and the patient was started on daily azithromycin, ethambutol, and rifampin. He was referred to us with cavitary Emmicasin after being persistently 4+ smear positive with heavy growth on culture. And so the recommendations for fibrocavitary or severe multilobar nodular bronchiectasis are a bit different, though it recommends the same base drugs of a macrolide, ethambutol, and rifampin. The recommendations here are for daily dosing. Rifabutin may be substituted for rifampin, which may have a bit more activity, though as we saw in the prior example, may be less well tolerated. And then an injectable agent such as Emmicasin or streptomycin for the initial 2 to 3 months. Emmicasin is preferentially used. It's more difficult to get streptomycin and you can't follow levels on it. These drugs are also recommended for macrolide-resistant disease. So our third question, in patients with MAC pulmonary disease who were initially put on the standard 3-drug regimen and failed to respond after at least 6 months of guidelines-based therapy, which of the following should be added? And your choices are an oral quinolone, an intravenous Emmicasin, inhaled Emmicasin, the parental formulation, or Emmicasin liposome inhalation suspension. If you could enter your answers. Okay, so most of the respondents selected D, amikacin liposome inhalation suspension. B is not incorrect, but I'll emphasize why we're talking about D here, and the other two answers are specifically addressed in the guidelines as not being appropriate, at least as the initial intervention in a patient is described here. So alternative drugs to consider if what you've done in response to what we've described so far is not working. There are other drugs that can be considered. Just realize that the evidence to support these drugs is a lot less than what we've just covered. And those drugs would include clofazimine, which is a drug that needs to be obtained under an IND protocol from Novartis, a very old drug that's indicated primarily for treatment of leprosy. Oxazolidinones, linezolid, and tedizolid have very good in vitro activity against MAC. Bedaquiline is indicated for MDR-TB and also has good in vitro activity. I put a question mark by quinolones there. They're frequently used as a drug substitution, but the evidence for their effect against MAC is fairly weak, and there is evidence suggesting that they may not be great drugs, such as the fact that if they're added to a macrolide alone, the occurrence of macrolide resistance is the same or actually worse than the macrolide monotherapy, but they can be an option to consider. Inhaled Emmicasin, parenteral formulation, I'll talk a little bit more about evidence for that. And then the FDA-approved drug for treatment refractory disease, Emmicasin liposome inhalation suspension. So in a patient with cavitary disease, as we just shown, if that patient doesn't respond to augmenting their drug regimen, what about surgical intervention? Well, the data we have comes primarily from non-CF patients, and this study had 134 patients with focal bronchiectasis, such as shown on the two CT images there. 88% of the patients in this study had CAVIUM Complex, and they underwent thoracoscopic resection. There was no mortality or major complication in this study, and minor complications, which consisted primarily of prolonged air leak, were seen in 12% of the patients. In long-term follow-up over 23 months, 84% of them achieved culture negative status, and if you compare that to the details I went into for response to drug therapy, that's actually pretty good. 8 patients had relapse or reinfection, and interestingly, 16% failed to convert, but of those ones that did convert, their likelihood of microbiologic recurrence during those 2 years of follow-up was significantly less than what we saw with patients who had initially responded to drug treatment. So surgery may be an option in non-CF patients, and there are other studies similar to this which provide fairly good evidence to support that. How about in cystic fibrosis? Well, the CF guidelines state lung resection should only be considered in extraordinary circumstances and in consultation with experts in the treatment of NTM and CF. There are probably multiple reasons to be a little more hesitant in CF, most notably nutritional differences may play a role in surgical outcomes. This may be different now with effective CFTR modulator therapy, which would kind of equalize the nutritional status of patients going into this, but at least the current recommendations are to proceed with caution. So let's switch gears in the remaining time and talk about M. abscessus, which is orders of magnitude more difficult in terms of management than MAC. And I'll start with sort of a case that has been published in the literature. And the question here is when to start treatment. And so these are all from the same patient, time points in the course. A is the beginning, 19-year-old diagnosed both with CF and M. abscessus at the same episode, presenting with hemoptysis, recurrent respiratory infections, bronchiectasis. A BAL was done twice with smear negative, but culture grew M. abscessus. The patient had a biopsy that showed granulomas and focal necrosis and was smear positive. B, 6 months after diagnosis, there was a slight drop in FEV1. The patient was treated, as we discussed for CF, with IV antibiotics against Pseudomonas and staph. With no change in FEV1, culture remained positive for M. abscessus, smear negative. C, 4 years after diagnosis, FEV1 has dropped significantly. The patient was treated again with IV antibiotics with some improvement of FEV1, but characteristically, as has been seen, not back to baseline. Culture remains positive for M. abscessus and is smear negative. And then 10.5 years after meeting the diagnostic criteria, FEV1 drops again. Patient now presents acutely with fevers, no response to IV antibiotics. BAL is positive, smear positive, only grows out M. abscessus in heavy amounts, no other organisms, and a new cavity is seen on CT. So if you can select your answers from those 4 choices of when you would initiate treatment. Okay, so this question is a little bit unfair because there is no right answer. And so I can tell you what I would have done, which is probably A, which the majority of you selected. But what was actually done was D. And again, this case was published actually several times in the literature. This is one of Andy Collins' patients. And if you look at the time course of FEV1 decline in this 19-year-old patient back in 1985, over those 10.5 years, the rate of decline was about 1 to 2% per year, which on average was about the expected rate of decline for an adult with cystic fibrosis. And if you look at where the arrows point to IV antibiotics, again, you see a fairly typical response, especially in the second course, where you get this picket fence type appearance, but not going back up completely to baseline after treatment. Things really changed, though, in about 10, 11 years after this patient's initial presentation with this acute change. And what was seen at the point of B here, after having some mild changes on CT scan, but had the development of a thick-walled cavity, the patient was started on anti-mycobacterial treatment. And at C, the cavity had gone away after 6 months. Treatment was then stopped, which was probably too early, and the whole scenario repeated itself again with a cavity forming in a different location and the patient responding again to treatment. And so this represents one of the difficult things about M. abscessus. If this was, treatment with, an oral antibiotic like you would treat streptococcal pneumonia in a patient with mild disease, we wouldn't be having this discussion. The problem is that treatment is very complex. And if treatment had been started back at the time of diagnosis, that would have been maybe a long period of time of treatment with these toxic drugs was somewhat difficult to gauge response. And it doesn't necessarily mean that the patient wouldn't have had the same course of the subsequent period of time. So what we don't know is what changed around the point just prior to A that made this take a different course. Is this a host-related factor? Is this microbial changes? Would it be possible if we were smarter to look at genomic changes in the organisms and to be able to get a prognostic indicator of when to initiate treatment? Unfortunately, we're not quite there yet, but hopefully sometime soon. It's very, very important with M. abscessus to know the most that your microbiology lab can tell you about the organism. The subspecies, or more importantly, the resistance to macrolides associated with the subspecies, makes a huge difference in treatment response. And if you look at this example from the regimen, this patient underwent a month of a very complex treatment regimen, followed by 2 years of an oral sort of maintenance regimen. This is not unlike the guidelines recommendations, which I'll discuss on a subsequent slide. And if you look at just the microbiologic response here, patients that had subspecies abscessus only had a 25% microbiologic response compared to those patients with subspecies Macilliense, which had an 88% response. And this microbiologic response correlated with symptomatic and radiographic improvement. So what is the difference between those two subspecies? And it relates to molecularly determined resistance patterns. And so the macrolides actually have 2 different mechanisms of developing resistance. In the top row, this is constitutive resistance which typically occurs from conditions like prolonged macrolide monotherapy, where patients acquire these point mutations that result in sort of garden variety resistance occurring. More commonly is inducible resistance, which is associated with this erythromycin ribosomal methylase gene, whereby in the presence in culture of macrolides or in vivo, over a period of time, these isolates will turn from susceptible to resistant. And so if your lab is reading typical phenotypic plates at 3 to 5 days after inoculation, they may appear initially susceptible. If they're held between 7 and 14 days after inoculation, somewhere in that time point, they will turn resistant. And it has to do with the induction of this gene. So subspecies abscessus, the vast majority of them have a sequovar that results in inducible resistance. About a little less than a third, about a quarter of them have a sequovar that constitutes full susceptibility. And this is a point mutation in that gene. Macilliense, on the other hand, almost all of these have a large deletion that renders this gene inactive, and these organisms retain their macrolide susceptibility. And so knowing the subspecies will give you most of the information you need, but what you really want to know is the sequence of this ERM41 gene, or in phenotypic resistance held in the lab up to 14 days to look for this induction. Aminoglycosides also have a molecularly identified locus for resistance, and patients that have an isolate with mutation in the 16S ribosomal RNA gene have high levels of resistance to aminoglycosides, and those patients don't respond to IV or inhaled drugs. So these are relatively uncommon, but when present, those patients won't respond clinically to Emmicasin. So this is what the treatment chart looks like for M. abscessus from the guidelines, a little more complex. The antibiotic regimen shown there constituting an initiation and continuation phase, which I'll go into a little more detail. A bit more monitoring required in terms of blood tests, amikacin levels, audiometry now because of aminoglycoside use, and EKGs because of multiple drugs that can affect QT interval. So this intensive phase should include a daily oral macrolide, preferably azithromycin, and 3 to 12 weeks of IV amikacin plus one or more of the following drugs that are guided but not dictated by susceptibility tests, and those are tigecycline, imipenem, and cefoxitin. The newer literature in patients that fail to respond to those drugs, you might consider things like using dual beta-lactams that attack different moieties of the beta-lactamase, or using newer beta-lactamase inhibitors combinations such as avibactam or relebactam. The duration of this intensive phase should be determined by the severity of infection, the response to treatment, and how long you can have a patient willing to keep a PIC in place to receive IV drugs. The continuation phase should include a daily oral macrolide, with the caveat that if the patient has either constitutive or inducible resistance to the macrolide, it can't be counted as part of the mycobacterial regimen. There may be reasons such as suppression of Pseudomonas or its immunomodulatory effect that may may make it desirable to leave that in the regimen. The conversion of IV amikacin to inhaled amikacin is recommended at this point, and 2 to 3 of the following oral antibiotics, again guided but not dictated by the susceptibility test. Minocycline was recommended in the guidelines, though omadacycline appears to be more effective in vitro and sort of equivalent to tigecycline, and may be a consideration for a drug that comes in both an IV and an oral form. Clofazimine, which we discussed, moxifloxacin may have some activity, and in an oxazolidinone like linezolid or tadizolid in vitro tend to have good activity against these drugs. While rifampin has no activity against M. abscessus, there's been more recent literature suggesting that rifabutin does, and this may be an oral drug to consider as well. In a couple of slides about inhaled amikacin as we wrap up here. This was from a small study we did a number of years ago in 20 patients who were on failing drug regimens. The majority of these had M-abscessus, 25% had Emmicasin complex, but on average, these patients had been on failing regimens for 5 years with consistently positive cultures. They had inhaled Emmicasin added as a single drug onto their failing regimen. It was off-the-shelf Emmicasin at a dose of 250 milligrams diluted in 3 mLs of saline as a place to start. We used a regular jet nebulizer and then tried to titrate that up toward 500 milligrams twice a day. Dosing was limited primarily by dysphonia, and most of the patients received 250 milligrams dosed once a day. The graph on the left-hand side of this slide represents the culture status after adding Emmicasin, inhaled Emmicasin at 0.0. Within about 3 to 6 months, a fair number of patients achieved negative cultures represented by the blue circles, and overall 40% of these 20 patients achieved a negative culture, with 25% having sustained culture negativity. About 35% of them stopped drug before the desired endpoint, and this was due to a variety of things such as ototoxicity, hemoptysis, reversible increase in creatinine in one patient, and persistent dysphonia in one patient with vertigo. This study led to the planning of a clinical trial that was done for a novel formulation of a liposomal encapsulated Emmicasin made for inhalation. And in the phase 2 study, we enrolled CF and non-CF patients and patients with MAC or M-abscessus predominant disease. And they were randomized either to continuing their failing regimen. These were all treatment refractory patients, or their background regimen plus placebo, or their background regimen plus active drug. They were then followed monthly, and you can see as early as day 28, there was a significant difference in achieving culture negativity represented by the blue bars there compared to placebo in the gray bars. And by the end of the randomized period of day 84, this was a very significant difference achieved between the two groups. The crosshatch areas represent M-abscessus, which was underrepresented in the study. The culture status change correlated with improved distance achieved on a 6-minute walk, and this led to a subsequent phase 3 trial that was done only in patients with treatment refractory MAC who were non-CF patients. The results were almost exactly the same as what was seen in the phase 2 study, and by month 4, 30% of the patients had culture converted, which represented 3 consecutive negative cultures versus 9% in placebo. Unfortunately, as with many inhaled drugs, there was some airway toxicity from this drug, particularly over the first month or 2 of taking it, which consisted primarily of dysphonia, cough, and dyspnea. Some patients had drops in their FEV1. Generally, those side effects, if they're treated, the patients are treated symptomatically, will begin to wane after 1 to 2 months on the drug. And again, this is the only drug indicated, and its indication is for managing treatment refractory Emmicasin complex in adults without CF. And then in terms of getting back to M-abscessus, the toxicity monitoring is very, very important, similar to what we discussed for Emmicasin complex, but the number of drugs tends to be higher and the toxicity can be more pronounced. And so looking at drugs like sulfoxaflor, this may be tolerated well initially, but is a poor drug for long-term use. Patients typically develop things like fever, rash, eosinophilia, interstitial nephritis, cytopenias with it. Makes it difficult to keep in the regimen. It also has to be dosed fairly frequently because it's rapidly cleared by the kidneys. Clofazimine, a pretty well-tolerated drug. 75% or more of the patients will develop a skin discoloration, which in most patients appears as a bronzing or a darkening of the skin. It can also cause some drying of the skin. It's a sun sensitizer, and so patients that are in heavy sun areas need to make sure they're using sunblocks because this can cause problems. Very, very rarely, and I've seen this in at least a couple of CF patients over about 30 years of using this drug, it can cause a focal bowel wall obstruction or enteropathy, which symptomatically can present very much like a CF patient who has been non-compliant with pancreatic enzymes. So loose fatty stools, abdominal cramping, typically present with low albumins. Just an important thing to keep in mind if you use the drug, though it is very, very rare, especially the doses we use now. Emmicasin is generally pretty well tolerated. The oxazolidinones with long-term use can cause cytopenias, peripheral neuritis. Frequency of optic neuritis is about the same as ethambutol. Moxifloxacin, commonly used drug, it may have some GI side effects, some CNS side effects in older patients, and can prolong the QT interval. Minocycline, photosensitivity, GI side effects, vertigo, and tigecycline can be a bear to tolerate in many patients. So I've generally found that the younger CF patients tolerate it better than my older patients do, but it can cause some profound nausea and vomiting and can be associated with pancreatitis. It's just again important to keep in mind. On the horizon, this is now a somewhat dated slide, but there are a variety of drugs in different phases of clinical trials. There's probably 6 to 8 drugs that are completing preclinical testing and awaiting entry into clinical trials. This landscape has changed completely for me over the last 5 or so years. For the first 25 years of interest in this, not many other people were interested, and there certainly there wasn't any activity in terms of drug development. That has changed quite a bit, and I think that's been spurred along by having a route for FDA approval of drugs for this indication being shown. So I'm hoping that in future talks, this list of drugs will change, and we'll have drugs that are better tolerated and hopefully for shorter treatment regimens than what we now have. So I'll stop there, and I'm happy to take any questions that you might have.
Thank you very much, Dr. Olivier, for that talk. There's really a lot of information. If anybody has any questions, please type them into the chat. You can also ask to be unmuted.
Dr. Sanders, we don't hear you.
Oh, you're not able to hear me?
Now we do.
Okay. I wasn't saying anything. Sorry, I had to step away for part of the talk, so I don't know what questions you already answered.
I don't see any questions in the chat yet, because I do have it open. Feel free to do that, or just open your mic, unmute yourself, and ask them. We'll be happy to discuss that.
Yeah, maybe one question I had, maybe you addressed this already. Do you stagger the start of medications for M. abscessus in order to look for side effects?
Well, that's actually a very good question. It's a little different for M. abscessus because we're generally starting them on IV drugs up front. And so we may stagger it a bit depending on what drugs we're combining. But generally, we've either admitted the patient to start this, or we've put a PICC line in and then giving them the initial doses that are IV drugs in-house. So I will generally get that started first and then begin adding oral drugs if we're going to add those up front to the regimen. But the way that M. abscessus is treated with these sort of 2 phases, which, by the way, is still somewhat controversial. There are many people that think that continuing these patients on non-IV drugs over prolonged periods of time doesn't add a whole lot to the treatment response. But we do stagger to a certain point, but not with the same sort of prescription that we do for CAVIUM Complex.
Okay, great, thanks. So it looks like there's a question in there. Can you see that?
Yes. So the question is, if a patient cannot tolerate a multi-drug regimen due to ototoxicity, is it worthwhile to use a single drug for M. abscessus? I have a CF patient who argues this point with us. I would highly, highly recommend against doing that. I think the first decision you need to make is whether or not the patient needs to be treated. And if the patient needs to be treated, whatever single drug you pick, you are sacrificing that drug, essentially. if it works, there's a high chance of developing resistance to it and a better chance that it won't work. So you may, you may be losing a potential drug that you could use in a multi-drug regimen by treating them with monotherapy. One question that comes up, which is sort of related to that, is in patients that you've successfully treated that remain at high risk of acquiring new infections, is it worth keeping them on a scaled down regimen? And the answer to that is not known. I think many people would hesitate against using a macrolide for sort of secondary prophylaxis, though I have to say that there is data from the CF registry to suggest that those patients with CF who are on chronic macrolides have a much lower incidence of acquiring NTM than those patients who are not treated with chronic macrolides. But I think the concern is that if they're on a macrolide alone and they have undetected NTM infection that comes back or comes anew again, that could lead to macrolide resistance. There is a study ongoing now in non-CF patients looking at the potential for clofazimine as a drug that could be effective as a single drug for secondary prophylaxis, but the results of that trial won't be out for a while.
Great, thank you.
All right, it's been a pleasure to have this opportunity again to talk to you this afternoon, and I hope this talk was helpful.
Yes, thank you very much.
Thanks a lot.